I'm a chiropractor from Spine Alive and Physiotherapy Center. So today I would like to talk about scoliosis and corrective exercise in the treatment of scoliosis. So these are the few things that I'm going to cover today, ranging from definition, demographic, type of scoliosis, how the anatomy looks like, etiology, physical examination, and etc. So I'll pay more attention in the diagnosis component, the classification system, and the importance of progression factors in order to determine what would be the best treatment plan. And also I will touch certain parts of the prognosis and the conclusion. Okay, so what is scoliosis? Scoliosis is defined as a three-dimensional curve with lateral curvature of the spine, with torsion of the spine, chest, and there will be some disturbance not only limited to the frontal view, there will be also some limitation to the side view. Okay, so what will be the demographic affected? Usually it occurs 1 to 3% of population below the age of 16 and 0.1 have a curve greater than 40 degrees. And if you are talking about curve bigger than 30 degrees, usually it affects girls more than boys, outnumbering by 10:1. So what are the types of scoliosis? There are several types. Idiopathic scoliosis is one of the most common one, taking it about 80%. The rest would be congenital, which could be a wedge vertebral, block vertebral, neuromuscular component due to neuromuscular dystrophy, or could be a paralysis of the limbs, weakness of the muscles, syndromic being Marfan syndrome, connective tissue disorder, or even neurofibromatosis. So some tumor to do with the nerve tissues. Okay, and also there's another category which is degenerative type. So degenerative scoliosis usually affects elderly people that hits menopause. And for idiopathic scoliosis classification, there's 3 different categories ranging from infantile, juvenile, and adolescent. So if we look at this infantile age, the age group would be anything between newborn baby to age 3 years old, and it accounts about 5% of the population of idiopathic scoliosis. So juvenile would be 4 to 10 years of age, accounts 10.5%, and adolescent is something that I look after most of the time, which is age from 10 to 17 to 18, which is about 89% to 90% of the population. Okay, so usually in the clinic, what I will see most of the time would be adolescent idiopathic scoliosis, and it is really important to take good care and to manage this group of patients properly. If being left treated with the improper treatment plan, the prognosis will be really poor. Okay, so anatomy. So how does a scoliosis spine looks like? So usually all bony components, elements are altered. There will be a convex side and also a poorly developed musculature at the concave side. You will notice some pedicle rotation where you see the pedicle tends to disappear towards the concave side of the spine area. And besides the normal thing that we do see from scoliosis patient, which is a lateral shifting of the vertebra and some rib hump and some wedging of the vertebra and also the disc. Okay, so etiological theories. What are the few categories behind? Genetics. Genetics meaning it tends to run in the family most of the time. So if your auntie has them or your mom has them, chances is that there is a higher tendency of the kids or the children to inherit this scoliosis issue. Tissue deficiency could be something similar to Marfan syndrome, where there is a poor or underdeveloped or less differentiation in the tissue, so it will cause some form of lateral deviation of the spine as well. Growth, and also the rest would be the growth abnormalities and central nervous system alteration. So let's talk about the next slide, which is determine the severity of scoliosis. So scoliosis is only defined anything more than 10 degrees in X-ray through corpse angle. So for mild scoliosis would be anything between corpse angle of 10 degrees to 20. moderate would be 20 degrees to 40 degrees, and severe scoliosis would be 40 and above. Alright, so now we are talking about the physical examination. So what should you check when you see a patient who has scoliosis? I will often get them to remove their gown with their back exposed, so we can actually have a good look at the shoulder level, the pelvis level, and also the shifting of the curvature. Okay, so what you see over here, usually I'll suggest we roughly have a plumb line from C7 all the way down to the sacrum region. So when you draw a line down, you may see that there is some shifting of the body towards the right side. Okay, oftentimes we do neglect the sagittal profile. Sagittal profile is something that we need to take into consideration when we treat scoliosis. So having a good thoracic curve, kyphosis of the thoracic, and lumbar side of the lordosis is better than having a flat back. The flatter the curve is from the side view, the worse the prognosis of the treatment. So having a good sagittal profile does give us some information about the prognosis of the case. Okay, moving forward would be the diagnosis and early detection. So it's really important to start checking and to do some postural screening, especially in school children, because the thing is, normally adolescent idiopathic scoliosis happens around age 10-11. And for ladies, if can, age 8 to 9 would be a good time for mom. You can educate the mom, or since you do have scoliosis, it's actually good to ensure you do check on your children's back every now and then, especially for female as young as age 8 to 9. And for boys would generally be age 11 to 12. Okay, so the detection can be done as simple as getting the kids to do a simple Adams test and to see whether is there any hump on one side of the body. And for us, a practitioner that looks after patients, it will be good to at least have the scoliometer tool in the clinic so that it helps to assist. So scoliometer is where we measure the axial trunk rotation. So this one gives you an identification whether, is there a need to refer the patient for an x-ray. Often we do not know at which stage should we refer the patient out for an x-ray. So this will be an assisting tool to help us identify, okay, if the patient has, let's say, this is 0, usually we will need to place it at the sacrum first when we want to identify the lumbar component. So you will need patient to put their hands together with their feet shoulder width apart, get them to bend forward without having their hands leaning against their thigh. So with that, when they bend all the way down, okay, let's say you stand straight this way, you get the patient to stand straight, hands together, bend all the way down, ensure the back is parallel. If you are checking for the lumbar component, you need to ensure that the lumbar component is parallel to the floor. Okay, same goes to the thoracic. If you are checking for the thoracic curve, you need to make sure that the thoracic is as parallel as possible to the floor. So from there, you start with a reading 0, and then you go towards the area where you see the biggest hump and the biggest value. Okay, so anything more than 5 to 6 would be a good indication of them needing to take an x-ray. So for some practitioner, for me personally, I will take into account their age and also how their physical examination looks like, and also scoliometer reading. We cannot just 100% rely on this tool. So there's a few things that you need to take into account. Minimum of 5 degree, you need to look at the physical examination, and then also the age group. Okay, so next, when you do an Adams test, often what you see is a thoracic hump on one side with a pelvis shift to the opposite side. So this is how an Adams test looks like. So for x-ray, once you've decided to refer this patient over for an x-ray, there's a few important points to look for when determining or looking for the scoliosis curve. One would be the plumb line. The plumb line would be anything from C7 from an x-ray you need to draw. Usually, we will refer for a full spine x-ray, AP and lateral, within the same film. So from there, you are able to draw a line from C7 all the way down to the sacrum. So this is the plumb line for the coronal plane, AP or PA. So the next one would be a sagittal plumb line as well. Same thing, C7 all the way down to sacrum. So from there, you are able to see which one would be the major curve. Is it the thoracic or the lumbar? Besides calculating the corpse angle. Corpse angle would be the gold standard to measure the degree of scoliosis, which I will cover this shortly. And riser sign would be how ossified or how mature the pelvis is. Okay, and the apex of the curvature would be the vertebra that is most lateral from the plumb line. Rotation of the pedicle would be how twisted the vertebra is. So these are the few things that I would actually look at when it comes to scoliosis patient. Not only corpse angle, not only the riser sign. So important note to take into account would be all this. Okay, so corpse angle. So corpse angle, as mentioned, is the gold standard. So what we measure is generally we take the most tilted vertebra from the top, we draw a parallel line, and we also identify the most tilted vertebra on the bottom, and we also draw a parallel line. So once these two lines intersect, we can get the corpse angle. But however, most of the time when you get an AP film, you are not able to really coincide these two lines. Hence, a perpendicular line is drawn towards all these lines. Okay, so you get this vertebra, you get this vertebra, and you draw a 90-degree perpendicular line, and you get the corpse angle as shown from the cursor. Okay, so riser sign. Riser sign tells us the percentage of the ossification of iliac epiphysis. So this one also tells us how much the cartilage has turned into bone, and to determine which stage of puberty or which stage of growth stage is the children in. So for stage 1 stage 0, meaning they haven't started their puberty yet. Stage 1 would be anything from 0 to 25% over here. 2 would be 50, 3 would be 75, 100 would be 100%. So 5th would be it totally fills into the ileum. So these are the stage where it's important to take notice during the x-ray. Okay, so rotation. So spinous rotation is where spinous process rotates into the concavity. So usually we do follow the Nash and Moe method, where you see on the left side here would be the convex side, where you can look at both pedicles being next to each other. So the concave side would be on this side. As the grading goes on, you will see that the pedicle on the concave side starts to disappear. Okay, this one also tells us the prognosis and how severe the scoliosis is, besides looking at the corpse angle. So for vertebral rotation, the category goes by plus, plus plus, triple plus, and 4 plus. So all this tells us about how much or the estimation of the rotation of the vertebra. There's also another tool that we can use called a torsiometer that identifies how much is the angle of rotation of the vertebra. Okay, moving next would be the classification system. So oftentimes we do classify scoliosis as right thoracic curve or left thoracic curve or levo, dextro. So by right, there's other classification, which is King's classification. There's also Lanke's classification, and another one which is the augmented Lynette-Stroff classification system. So this one is mainly for people who is going through bracing. Specific bracing would be the Cheneur concept Jessingham brace. So this one would be the other component that I will talk about later. So King's classification. One of the classification of scoliosis being utilized. So you see from grade 1, 2, 3, 4, 5. So it's being classified according to the first one would be a double curvature, being lumbar curvature as the major curve and the stiffest thoracic spine. Second would be a double curvature with a wider thoracic or bigger thoracic curve with a stiffer lumbar curve. Third one would be solely a right thoracic curve or a single thoracic curve with no lumbar component. The fourth one would be a major thoracic curve or long thoracic curve with no lumbar component as well, or lumbar component favoring the thoracic. So the fifth one would be a thoracic component, okay, with a proximal thoracic compensation. So this is King's classification. So the next one would be Lanke's classification system. This is even more complex, where there's 6 types of curve subdivided into proximal thoracic, main thoracic, and thoracolumbar and lumbar. So you can definitely go through this because this is really helpful. Structural and also non-structural. Non-structural meaning is a functional curve. Structural is more of something that is permanently fixed. So this few categorization you can check. The first one being a main thoracic curve, with the main thoracic curve being a structural curve. The second one would be a double thoracic, meaning proximal thoracic and main thoracic is affected, the upper thoracic and the middle thoracic being the bigger curve. And the third one would be a double major, meaning there's a main thoracic curve and also a lower back curve, which often that we see the S curve, with a proximal thoracic, meaning a compensation on the top, which is non-structural. So the fourth type would be a triple major with all major curve on different components. And fifth one would be main structural curve at the thoracolumbar and lumbar region. Sixth one would be thoracolumbar and lumbar main thoracic. So few things to actually take note. Please do go and study this because I find this really helpful. And also there's also a structural criteria and importance to identify the location of the apex for this classification system. So hence most of the time I do take into Lanke's classification system because it is more detailed, and they also do include the lumbar spine modifier, meaning when you draw a plumb line, does the line passes through the pedicle in between the pedicle of L5, L4, L5, or does it not touch? So all this information are quite important when you check for a scoliosis x-ray or scoliosis patient. Okay, so the other one would be an augmented Lennard-Stroff classification system. So this one is mainly for bracing purposes. So this is subdivided into 7 categories over here. 3, 3, 3, 3, meaning thoracic being the main curve. 4, 4, 4, meaning lumbar being the meaning there's a lumbar component in it. So you can see there's a few where they mention 3CH, H meaning a thoracic curve with a hip prominence, 3CTL meaning a thoracolumbar curve, meaning the apex is at the thoracolumbar junction with a hip prominence, 3CN curve meaning there's a thoracic curve, however with a more neutral and balanced pelvis, meaning there's no side shifting of pelvis like how it is on the second and the first image. So the third one would be 3CL. So 3CL means 3 curve with a long lumbar counter curve. So you may see from this area. And the fourth one would be a 4C curve, meaning there's equally big both thoracic and lumbar spine, convex curve. 4CL meaning a 4 curve, a single lumbar curve with a mild thoracic compensation or no thoracic compensation. And 4CTL curve meaning lumbar and affecting the thoracic spine region, or the apex of the lumbar is close to the thoracolumbar region. So all these are important note to actually look at, and you can see each and every single type of curve, the brace pattern is slightly different. Okay? So for 4 curve, sorry to mention that also, for 4 curve, you will notice a shifting of the pelvis more towards the right side. So sometimes in between, when we look at a thoracolumbar curve for 3CTL and 4, how do we determine besides the apex, we also look at the shifting of the pelvis and also the plumb line. Okay, so some patients who has scoliosis requires MRI. Who are they? People who have a big left thoracic convex curve. They are experiencing painful scoliosis, discomfort all the time, every day, and also sleepless nights. There's some neurological findings. There's weaker deep tendon reflex. There's arm weakness, and also some stiffness that is unexplainable. And also the other types would be a sudden, rapid progression of stable curve. So all these are quite concerning. Hence, an MRI is required to actually check out is there any other reason why it is causing all this to happen, rather than assuming that this is just another idiopathic cause of lateral curvature of the spine. Okay, so will the curve progress, and how do you estimate? There's a few ways that you can estimate what would be the treatment plan. One of it would be the progression factor. So progression factor over here would be incidence of progression according to progression factor, which is calculated by this formula over here on the bottom right. So we would often take corpse angle minus 3 times riser sine, whether is it 0 or to 5, divide by the age. So you will get the number over here, and once, let's say if you get a number of 0.6, this one would be an observation stage. If you get anything below 1.4, it will be still under observation stage. If it's something between 1.4 to 1.6, physiotherapy treatment would be recommended. Anything more than this range would be a combination of brace and intensive exercises. So common time, often what we do is we follow the SOSOC guideline, which is the Society on Spinal Orthopedic and Rehab Treatment. So if you do look into this chart, there is observation, there is physiotherapy, there is intensive rehabilitation, and anything be above 1.6 or 1.625 and above, you see outpatient physiotherapy, intensive rehabilitation, meaning besides coming in more frequent or seeing your patient more frequent for prescribed exercises and brace. So these are the things where how do we determine how often do we need to see the patient, or what would be the progression factor? Are they at risk of developing a further increment of curvature, or is their curve a more stabilized type? So this is a really good calculation that you can use. So I would suggest you to look into this particular formula. So this one is specifically for idiopathic scoliosis during their growth stage. Okay, so moving on would be maturity marker. So quite often when we do see a patient, especially adolescent or age 8-9, one of the few questions that is important is menarche. Have you gotten your first period? Okay, and then you do look at, is there any changes to their breast shape as you continue to look after the patient? And also a few things to look into would be armpit hair, facial hair, any voice changes, especially for male. Voice changes would be something that is important to look at. Okay, so these are the few charts that you can go back and look at it at home. So I'm not going to go into detail. So these are a few things that some of them do take into account. Okay, so for treatment plan, so there's a few things that is being mentioned by the previous SOSOC guidelines. Would be observation, physiotherapy treatment, intensive rehab, bracing, and surgery. So observation, how soon should you see your patient? If you do see a mild curvature in the patient's back, but it is still under a controllable manner, meaning it's not too obvious that the patient has a right thoracic curve and the patient is still really young. So if it's 8 or 9 years of age, it is good to actually follow up with them after 2 to 3 months. Okay, for physiotherapy treatment, so if it's patient that has corpse angle anything between 10 to 15, physiotherapy treatment once a week and also prescribed exercises for them to do it at home would be recommended. However, if the curvature is 15, 20 or 20 plus and above, intensive rehabilitation would be recommended. Guiding through the patient through individualized and specific exercises cater to the back or to the scoliosis would be recommended. So, and also bracing. Which category of the patient requires bracing? As we go back to this chart, you'll see anything from 1.6 plus or 7 and above would be a brace candidate. So another one would be corpse angle. What would be the recommended corpse angle? 25 degrees and above, or some as young as 20, depending on riser sign. Okay, so moving for observation, as mentioned, close monitoring would be suggested. So something between 2 to 3 months would be great rather than leaving it alone, especially if the child has a family history of scoliosis. Closer monitoring would be recommended. Okay, and also education, patient education, having a good upright posture, sitting posture, ergonomics, and also educating the parents about the importance of checking or looking at their kids' back once in every maybe few weeks. Get them to do a simple Adams test to look at whether there's any harm at certain areas. Okay, so PSSE, physiotherapeutic scoliosis specific exercises. There are a few types ranging from Schroff method, okay, Schroff best practice, and SEAS approach. So Schroff method is also a type of three-dimensional exercises developed by Katerina Schroff, which is further popularized by her daughter Krista. So Schroff method is a non-surgical treatment for scoliosis. It uses exercise that is customized for each or individualized to each patient so that we can return a curved spine to a more neutral position. The next one would be Schroff best practice. So Schroff best practice is developed by Dr. Hans Rudolf Weiss, which is the grandson of Katerina Schroff, and this is also a non-surgical scoliosis treatment that aims to reduce the corpse angle, and it is also three-dimensional, but these exercises focus more on overcorrection of the spine to the opposite side. Okay, so the aims are the same. Prevents progression of the curvature, reducing corpse angle, reduce the deformity look, improving the ATR besides the corpse angle alone, improve quality of life, aesthetic improvement, less shifted, less sunken or less underdeveloped concavity or concave surface of the musculature, reducing pain if for those who has discomfort and pain. And majority of the time I do see my patient without suffering from any discomfort. Even though their curve is as big as 60 or 80 degrees, they do not have sharp pain, disturbance of sleep. They are perfectly okay, perfectly normal. Only some discomfort if they were to sit for too long or being in the wrong posture or having a poor posture all day long. And also improving the vital capacity and chest expansion, especially those who have a big thoracic curve. So let's say there's a right thoracic curve and there will be an imbalances in terms of one side of the lung will be more squished, the other side will be having a lot more space. So when there's inhalation and exhalation, the pumping and also the expansion and constriction of the lungs would not be the same. Hence, it does affect the vital capacity. Okay, and also all this, the aim is also to improve and training for their ADL, activity or daily living, and to improve their movements in general. Okay, so what's the difference between Schroff best practice and Schroff method? Principle behind, still the same. One's to correct the thoracic curve or the lumbar component. One is to overcorrect to the opposite side. Let's say you have a right thoracic curve. While performing the exercise, there will be an overcorrection to the opposite side. On the other hand, for Schroff method will be correction to a more neutral standpoint. Position-wise, most of the Schroff best practice exercises are being done in an upright position, whereas Schroff method, most of it is in supine and prone position. There's also upright position for Schroff method. Well, it tends to interlap. So for Schroff best practice, it takes up more of the movements that you are able to do it at home. Hence, it's less reliance on props, while Schroff method is more reliant on props, sticks, and tools. So, for categories wise, Schroff best practice do trade curves up to 80 degrees, while Schroff best method would go all the way up to 100 plus degrees. So both are the same. It's just that there is some differences in terms of the movement, but their goals are still pretty much the same. Okay, so one of the important components of Schroff exercises would be the rotational angular breathing, RAB. So it creates a force to derotate the vertebra and also to reduce the appearance of hump. So it helps to expand the collapse areas during inhalation and stabilize the curvature as well. So you do see there's one concave side and the other one would be the convex side. So the convex side, often you see a rib hump on that area, while the concave side will be a sunken surface. So usually when doing the RAB or rotational angular breathing, the breathing most often is being done into the or breathe into the concavity side, so that this whole area you are able to derotate this structure. Okay, so which is better? To be honest, learn all would be the best. Having more knowledge, and most often time, the more you see, the more you teach the patient, you look at different pattern. There's no such thing as everything fits the patient according to the textbook. Patients are not textbook, so we will need to look at it and to see whether are they able to perform. Once they are able to perform, we would like to see how much they are able to cope with this movement. Okay, so these are the examples of the exercises. So you see some shifting of the vertebra. This patient has a right thoracic curve with a left pelvis shift. So she is shifting to the left side, and you see a correction of the curve to the left over here rather than being maintained at the right, with a pelvis drop down on the left and hiking on the right side. So you see the shifting of the pelvis is not the same over here on the corrected position. Okay, so these are also some of the example. This is what we call a kneeling position. This patient has a right thoracic curve as well. Once she's in this position, she is in more of a neutral curvature for her spine, much more of a straighter back. And this is how the setup of some of the Schroff method or Schroff best practice center. So you see a wooden stool, wooden bar. See wooden bar, people doing different kind of frog at the pond position, having a few sticks and also a yoga ball. Okay, so all these are it has scientific evidence to support, and a lot of times you see an improvement in corpse angle, axial trunk rotation, pain, and also how aesthetically they will look better, and improvement on the quality of life. Okay, so these are all the information available in internet. You can actually check. There's a lot of information on how Schroff exercises can actually help. Okay, and also there's few types of bracing available in the market, but the ones that pairs well with Schroff exercises are what we call Jessingham brace. So it applies 3-dimensional component, where it is not just a rigid brace that is symmetrical and it just wrap around your body. This one you may see some rotational component and also some appearance of holes when the patient is wearing the brace. There will be an area of pressure. Let's say you have a right thoracic curve, it will have a bit of an area of pressure that push this part of the upper back. And there's also a concave side or empty space where you upgrow the brace, it will push to the opposite side instead. Okay, so research thus indicates that asymmetrical loading reduces the growth rate of the bone, and also it increases the other part, the growth rate of the affected area. Okay, so the next one, this one would be a Boston example of Boston brace, which is more rigid and just symmetrical, and Jessingham brace would be something that is 3-dimensional. You see there's a small little hole over here. Okay, and you do see that there's a bit of a pressure point on certain area, and also there's some foam being placed at this area to reduce the pressure at the rib cage region, and also the dropping of the hips on one side. Okay, so Chenot concept, Jessingham brace goes by Chenot concept. Chenot concept means using pressure zones and expansion areas to positively influence the spine in three-dimensional way. So goals are generally to stabilize, okay, and also to improve the spinal degree. So you want to reduce the degree of angle, and you like to stabilize the curvature as well. So as for this one, it does not only look at the improvement of the coronal view, there's also improvement on the sagittal view and transverse rotational view as well. Okay, so prognosis. So generally what I would say is the flatter the sagittal profile, the worse the prognosis is. The later the patient is being braced, the poorer the prognosis is. The earlier the patient starts going through exercises and bracing, the better the prognosis is. If patient doesn't do their exercises regularly, and the prognosis will also be poor, or the patient is not wearing the brace regularly as recommended, the prognosis will also be poor. So all these are the effort between the patients and the practitioner to actively encourage each other, especially practitioners towards patient, encourage them to do their exercises more frequently and being done in the right manner. Okay, so conclusion would be, as the clear scientific evidence for efficacy of PSSE in scoliosis treatment, so it can be served for sole as one primary treatment if it's mild scoliosis, but anything that is towards moderate scoliosis curve, bracing and exercises would provide a better results. Okay, so if there's any question that you'd like to ask me, feel free to contact me through my email, or you can also check out our website at www.spinalife.com. Anyways, we do have opening slots for chiropractors. Those who's interested to join us, please feel free to drop us a text or email us at enquiry.spinalife@gmail.com. Thank you.